Okay, hi everyone. Everyone can hear me okay? Okay, good. Hi. So just give me a second. Um, okay, so let's begin. So how's everyone doing? Excellent. So today we're going to have the first episode of our ConfiTalk series. In which I and my other colleagues in Confidentis are going to talk about a specific subject related to each of the exams, each of the MDB process exams in each of the episodes. So today, which is the first session, we will actually focus on radiology. It's more like a practice session. All the ConfiTalk series are mainly practice sessions. And it's not a Q&A session, but I think these series are going to be really helpful for you guys to just practice and see how the exam feels like, and also to kind of evaluate your performance. So I'm going to show you the question, give you a couple of minutes, usually like 90 seconds for each questions. And then I will provide you with my suggested answer. If you have any question about the answers, we can discuss. And then if there is any important point about each of the X-rays, I'm going to explain. Hope that it helps you guys to kind of get more familiar with the approach that you guys should follow with this exam. So starting from the first case, and just a reminder that these X-rays are all from my own patients with their permission. So please respect the copyright of the X-rays. And yeah, let's begin. So the first question, I give you guys like 90 seconds, and then we'll go over the answer. So remember, in the exam, you also have like 90 seconds per question. So this is the time limit that you guys should also practice with. In case you like, you can send me your answers as well. Mm. No, you just send me the answer, and I'm not gonna make a poll because the way that the answers work in the exam is that each answer, each option has a specific kind of score. It's not like AFK that you should select only one option and the other options you cannot select. So just keep in mind that for the exam, you should select only the options that you're 100% confident with. If there is any option that you're not very confident, it's better to avoid. And also, um, at the same time, there should be a balance between the number of options that you select and number of options that you don't select. So if you just be super conservative, then you're not going to get any score. So like, you're not going to get the full score, because it's still, at the end of the day, you have to score like 75% to clear the exam. Okay. So let's see. The time is over. I see some of the answers. Okay, okay. Good, yeah, some of the answers are right. I'm gonna go over the options. And starting with the first option, which is periodontal bone loss. So we define periodontal bone loss as the bone loss which is caused by periodontal disease. And I can see some significant bone loss around technically all the lower incisors and canine, okay? So definitely we have periodontal bone loss. Another obvious thing that I see here is this guy here. So one calculus here, another calculus over there, and another one here. So this one might be a little bit risky though, but I think it's safe to select it at like calculus at that size. So option B is also the right answer. There is no caries. If you just pay attention, you see this area, it's a little bit risky. I see something is going on here. But the chance of having caries on lower incisors is very, very low, okay? So you have to also do the logic when you're choosing answers. Like a patient with this level of periodontal disease is very unlikely to have caries on lower incisors. So no caries. What about cervical burnout? Do I have cervical burnout? Some of you guys have selected cervical burnout, some don't. And the answer is yes, we have cervical burnout. So the cervical burnout that we have, I'll remove these. I have a cervical burnout here. Clearly, a little bit of cervical burnout even here. And maybe just a tiny bit here. So this one can be also a root concavity, but these two are pretty much cervical burnout. The other option that I have is abrasion. These can be abrasion, but they can also be attrition. So since I cannot make sure which one they are, I don't select. Root resorption, I don't see any. Pulpal obliteration, which means the complete absence of the pulp space. We don't have any. Shadow of the upper lip. So do we have shadow of the upper lip, guys? Do you see shadow of the upper lip here? Let me just, so answers that we have, A, B, D, and shadow of the upper lip. What is this? Anybody knows what is this line? Any idea what this line might be? Exactly. This is the shadow of the lower lip, not the upper lip. So this is the soft tissue. This is the shadow of the lower lip. So it's shadow of the upper lip. Doesn't show on the lower incisors. And we have the mental spine. I noticed most of you guys didn't select. I have mental spine here partially. Okay, so you can see some evidence of mental spine over there. Okay, no rarefine there is no cavity, there is no sign of trauma, no sclerosing osteitis. And tooth fracture, I don't select for this, although it can be a chip tooth, but too risky, so no. And there is no evidence of a foreign body. So the right answers are option A, B, D, and I. For each, you get 0.25. And if you select any other options, all the other options are -1. So it makes your question 0. Yeah. So if you get a score like 0.75, that would be a good score. Okay. for a question like this. 0.5 is not bad, but 0.75 is okay. It's considered as not a very difficult question though. So moving to the next question. So the horizontal image is really opaque. What do you mean? So guys, your 90 seconds is started from now. Which radio opaque line are you referring to? There is no foreign body, no. But remember, the definition of foreign body is an object which is inside the tissue, okay? So as long as that object is not inside the tissue where it doesn't belong, I don't consider that as a foreign body. So for example, the holder for the sensor, I don't choose foreign body for that for this exam, okay? Or if I see amalgam particle in the oral cavity, I don't select foreign body. But if I see amalgam particles inside the gum, then I select foreign body for that. Okay, so let's see. So most of you guys have selected periodontal bone loss. I'm just wondering, where did you select the periodontal bone loss for? Like, where do you see the periodontal bone loss? Just tell me the surface. Horizontal bone loss between premolars and molars. Nope, there is no periodontal bone loss. So all of you who selected periodontal bone loss, your score is 0 for this question. Distal of tooth 4-6, so borderline. So this is my CEJ. This is my bone level. It's still within 2 to 3 millimeter. I don't choose for that, okay? Compare this with this question. Look at how much bone loss we have here, okay? This is so borderline. So exam like this, borderline cases, I highly advise against, okay? So no periodontal bone loss, no calculus, yes caries. And something that most of you didn't select is a missing tooth. And that's why this area looks like this, looks like a periodontal bone loss. That's because a premolar was extracted and they moved the molar and the premolar to close the gap. So that creates this kind of appearance. So you have a missing tooth. That tooth was extracted because of orthodontic purpose, okay? Again, I know all of these patients. I've seen them. I know the case. I know the lady who's X-ray you're saying. So everything that I'm saying is with evidence. Attrition, I don't see any evidence, but I have external root resorption. A very nice case of external root resorption associated to the distal root, okay? Dense evaginatus that I see some of you guys selected probably because of this, but it's not a dense evaginatus. So no. A dense vaginatus, guys, tends to be a little bit longer, more elongated. And considering the fact that the patient is at this age, if the patient had a dense vaginatus, by now should have been worn down, and patient should have like something like rare phalangostylitis. I see some of you guys have selected pulpy stone. I don't see any pulpy stone here. So pulp chamber is normal, pulp chamber is normal, and even this one, pulp chamber is normal. Yeah, I don't even select calcification for them. Rare phalangostylitis, yes, we have. Where do we have rare phalangostylitis? Here and here. These are rare phalangostylitis. No sclerosing osteitis. Mental foramen, yes. Here is the mental foramen. Yes, foreign body. And the foreign body is the ciliar. You can see some evidence of ciliar here. Some ciliar and some ciliar here. There's also evidence of apical delta. And no focal osteoporotic bone marrow defect. So the answers are option C, D, F, I, K, and L. Okay. So 0.21, 0.2, 0.1, 0.2, 0.2, and 0.2. And all the other options are -1. So I have a comment from Vedant. Is there a little bit of calculus on the premolar distal surface? I don't see any. I think it's too risky. So let me zoom in for you. With this appearance, it's too risky. What about attrition on tooth 4-6? So that's a very good question. I don't choose attrition here because the tooth is severely restored. And I look at the adjacent teeth, okay? Actually, look at the adjacent teeth. Look how the cusp look normal. So it's very unlikely that you have attrition only on one tooth. Attrition is more like a generalized pattern, okay? Caries I have on distal of tooth 5 and on mesial of tooth 6, okay? So caries here, sorry, here and here. And what you see here is the endodontic access hole. That's radiolucency, is the access hole for endodontic lesion. So my question is, why this is rare phalangostylitis and not like apical scar? Why it's not an apical scar? So, you know, we have 3 types of scars. We have apical scar, we have surgical scar, and what is the third one? 3 types of scar that you guys should know: apical scar, surgical scar, and the third one is, excellent, bone scar. Okay, bone scar. So which one is this? This is none of them. Okay. In apical scar, it's radiolucent area, well-defined. Very good answer by Purvisha. Exactly, because if it was an apical scar, the periphery of apical scar tends to be a little bit more well-defined. Okay, so some of you guys might say, "Oh, why?" But the root canal looks good. Okay, the root canal looks good, but that's because this X-ray was taken right after the retreatment. So this was the initial case. So the patient came to us with this situation and with pain, and retreatment was done for her. And this X-ray is after the immediately after the retreatment, okay? So actually, this is the X-ray the patient had usually around 1 year before this. So at the time that we did the root canal for her, the apical lesion was more like this. But pay attention to the border of the lesion, which is ill-defined. So that helps to differentiate it from apical skull, okay? Let's move ahead with this question. Panoramic, so as you guys know, 3 X-rays are really, really important for this exam: preapical, bite wings, and panoramics. You may get occlusals as well, but your main focus should be on these 3, okay? So here we have a pan, and there we go with 90-second. Okay, so let's take a look. Guys, please be more like vigilant with the options that you select, and don't be super conservative, okay? I see some of you guys are just super conservative. Being super conservative is also not the best approach for this exam. Okay, let's take a look. So do we have periodontal bone loss? Yes, we do. So I see some periodontal bone loss here. Yeah. And I have more other areas with periodontal bone loss, but that's enough for me to select this option. Caries is more like a neutral option here. I think it's just too risky to select caries based on pan. Because of the quality of the X-ray, pan is not the best X-ray for a caries selection. I just choose caries when I'm 100% confident, but there is a good chance I have caries here, and there might be a chance that something is going on here, but again, too risky. I myself don't select caries, but if you select, that's a neutral option. So anyone who selected the option, that's neutral. What about impaction? Yes, we do. They have 2 wisdom teeth that the apex is formed, they're still under the bone, or they're still inside the tissue, so they're impacted. Do you see any root resorption? Not that clear, so I can select the option for root resorption, so no. No pulpal obliteration. A very borderline case of rare fungostitis. Where do we have it? I have it here. Very risky. Maybe it's safer not to choose this option, but I can see that lesion over there. That's like, you know, radiolucency. No sclerosing osteitis. but I have a foreign body. Which one is my foreign body? Implant is not a foreign body. Nope. Post is not a foreign body. Otherwise, you have to select foreign body for all the questions because they all have restorations. So they're not foreign body. 27 what? Calculus is not a foreign body. Exactly. Yes, that's the right answer by Amanda. So this is the foreign body. Let me just clear it. Okay. So this is my foreign body. A broken instrument. The broken instrument on 227 mesial canal, mesiobuccal canal. Okay. Overhang can also be, this one can also be a foreign body if it's inside the soft tissue. It's very likely that this amalgam restoration is inside the soft tissue. So for that, you can select overhang. So makes sense to me if you're selecting for this one. Ectopic eruption, absolutely. These two are erupting ectopically. Okay. Soft tissue calcification. Yes, again, borderline, but I can see some evidence of calcified stylohyoid ligament. No antral pseudocyst, no jaw fracture, and no torus. Okay. So impaction will go under ectopic eruption? Not necessarily. Ectopic eruption means erupting in the wrong direction, okay? Which may or may not result in impaction. So we have teeth that are erupting ectopically, but they erupt like fully, like canines. But many cases that you have impaction are because of ectopic eruption, okay? Do we have condensing osteitis on 3.6? I don't select for 3.6 again. I don't see the reason for that. I don't have an endodontic lesion. I have just a restoration, so too risky, no. 1.6, should I select pulpal obliteration? Absolutely not. For a case like this with this quality of pan, selecting pulpal obliteration based on a panoramic is too risky, okay? Again, remember for panorama uh, for pulpal arbitration, it should be a preapical. For caries, preapical. For calculus, preapical. Unless it's so obvious, unless it's like very clear that you have caries or pulpal arbitration. Do I have a pseudocyst in the right sinus? No, just overlaps. So no, the answers are ACF, HIJ. And moving to question number 4. So 90-second begins. Uh, okay, so let's see. Let's see your answers. Okay, let's just go one by one. So option A, periodontal bone loss. I don't see any. There might be some periodontal bone loss uh, over, just give me a second, like in this area. But again, too risky. I don't select. Do I have cervical bone loss? Yes, we have cervical bone loss. Sorry, cervical burnout. I said cervical bone loss. Cervical burnout, do we have any? Yes, we do. I can see quite a few of them on multiple teeth. So yes. So option B. Option C, attrition. I see multiple attrition. Let's pay attention to the attritions. You can see here, here on the incisors, lower incisor, premolars. There is no root resorption. Mental spine, yes. We had it in the first X-ray. We have it here. Rare phalangostylitis, I don't see any. So option G is saying bone scar. What do you think, guys? Do you think this is an example of bone scar? What is bone scar? It's a healing socket. Yes, that's correct. It's a healing socket. But can this be an example of bone scar? So bone scar is radiopaque, and I can see radiopacity here. So you have radiopacity. You have increased radiopacity over there. Okay. So the answer to this question is bone scar for this is a neutral option. Okay. This is not a very typical example of bone scar, but it can be considered as a bone scar. Okay. Because like a bone scar is defined as the radiopacity that is left after the tooth extraction because of, for example, a condition like condensing osteitis. So this is pretty much like that. It needs to be a little bit more significant to select it, but it's still, if you select bone scar, that's a neutral option. No jaw fracture, no foreign body, no calcified lymph node, but we have a calcified stylohyoid ligament here and over there, okay? And no cyalolite, okay? So answers are option B, which is 0.3, 0.2, 0.2, and 0.3. Okay. So let's go to the next question, question number 5. So is it genial to, it's mental spine, the one that you saw in the previous X-ray. The mental spine is exactly where you see on the X-ray in the midline. It's toward the lingual aspect of the mandible. So we usually have 4 mental spines, but it appears as that's kind of characteristic radiopacity that you see on the X-ray. But just remember, mental spine is the other name for genial tubercle. So what you're saying is not wrong. But mental spine and genial tubercle, they can be used interchangeably. No, it's not mental protuberance, it's mental spine. Okay, so let's just check the question. A very important point about this question is the first step is reading the question properly. Okay, read the question properly. Previous question, the question is saying the radiograph shows evidence of. But this question is saying for tooth 3-6. So it's asking about only about one tooth. It's not asking about what you see on the X-ray. And I see some of you guys didn't read the question carefully and just selected, for example, calculus, which is not the case. Okay, we don't have any calculus in this tooth. Anyway, so we have bone loss and mesial and distal. So A and B, obviously. We have caries on mesial, and we have caries on distal. Okay, this caries has extended to the root. For root caries, I choose neutral because for root caries to be selected, I'd rather selecting just those cases that I'm 100% confident the origin of the cavity is root. Here, I cannot confirm that the origin of cavity is root or it's just a crown carious lesion that has extended to the root. If you selected root caries, that's neutral, that's not wrong, but safer not to select. This is a root caries, for example. Okay. So as you see, it started from the root and it extended upward and it is just undermined the enamel. Okay. No calculus, no cervical burnout. Okay. So what you see on the distal is simply root concavity, like here. And here as well, there is no evidence of radiolucency, no abrasion, no root resorption, no pharyngosteatis, no sclerosing osteitis, but I have a furcation radiolucency here. And that's the answer. So 0.2, 0.2, 0.2, 0.2, and 0.2. All the options that I just draw a line on are just -1. They are just completely wrong answers. What you see here is a prefabricated post. It's not a casting post. And the restoration is also a composite restoration. So when it's a casting post and core are a single body. So they are not two separate things. Okay. For rare phalangosteatis here, I see some widening of PDL, but again, the size is not large enough for me to select rare phalangosteatis. I would say rare phalangosteatis would be a neutral option though. Something is going on over there. So my bone level is, so one of you is asking, can you define the bone level? And the bone level is this. So this is my bone level here. This forcation radiolucency that you see here is not because of periodontal disease. This is because of endo problem. So this case had a forcation perforation on the mesial surface. So this is typical of cases that we see with forcation associated with an endodontic lesion rather than, periodontal lesion. Okay, so A, B, C, D, and L, the answers. Just let me just show you some other stuff we see on this X-ray. So I have root caries here. Root caries here. So 2 root caries. We have calculus over here. Explain the bone loss and mesial. So guys, this is my CEJ. This is the bone level. This is more than 3 millimeter, okay? So we discussed the concept in our course, in our comprehensive ACJ course, that we look at the size of this triangle. If the size is getting bigger than normal, that is a sign of periodontal bone loss, okay? And it is getting like larger than what is supposed to be, okay? So the triangle approach is the easiest way to select cases that you're in doubt when it comes to periodontal bone loss, especially when cases are borderline. Question number 6 and 98 seconds. What about shadow of the bone you see? So that shadow is probably for the lingual bone. We always go with the most apical shadow. That's either for lingual or buccal. We can determine, but we have to go with the one which is located more apical. Okay, so let's take a look. Um, what do we see again? Question is asking about 2, 6. It's not asking about what you see in the X-ray. So your focus should be here. Okay, ignore all the other T's, like they don't exist. Okay. So again, the triangle technique, very large, bone loss mesially, bone loss distally, both of them. Okay. And I see most of you guys have selected caries and mesial. Where do you guys see caries? I can't see any. I don't see any. No caries. No caries. No caries. What you see here is not caries. And I explained what this one is, okay? But the root caries doesn't look like this. This is not how the root caries lesion they look like. This is a concavity created by root resection. So the mesiobuccal root was resected. And when you have this tooth resection, that creates a concavity on the root surface. And that concavity, that appears as radiolucency on the X-ray. Okay, so that's why it looks like this, you know, radiolucency. So it's not a carious lesion. Okay, and here you had a cavity, but it was restored. Okay. This radiolucency that you see here, that's not enough to be called caries. And this line that you see here is simply a match band effect. Let me just zoom in. Okay. For root, the same is for distal. The same for distal, no caries. One of the reasons that we have this situation, you can't zoom in the exam, guys. One of the reasons that you have this appearance, you know what it is? It's because this tooth has a buccal restoration. You see this opacity, this big opacity. This big opacity is a buccal restoration. And that kind of creates that, you know, a specific appearance. It's actually, it's more like this. This is how the buccal restoration is. So A and B, no separated instrument. It's not a hemisection. That's the whole point of this question. Not a hemisection. This is just root resection. Hemisection is associated with the removal of the tooth crown. Root resection is just for the root. Hemisection is mainly for the lower molars. Root resection is mainly for the upper molars. So nope, no root resorption, no furcation radiolucency, no preapical, and no prefabricated post. So the answers are just A and B. So if we check the definition of root resection versus hemisection, we see root resection involves the removal of one or more roots of a multi-rooted tooth while preserving the remaining root and crown. So the crown is completely saved, typically on molars, especially upper molars, okay? While hemisection involves the removal of half of a multi-rooted tooth, including crown and root. Most commonly on lower molars. We rarely do it on upper molars, okay? And if it, for the lower molars, if we cut it in half and keep both halves, then we call it bicuspidization. One more thing that you guys should pay attention to is this. You have rarefying osteitis and associated with this crown, Crown can be PFM, can be layered zirconia. This one all the same, PFM or layered zirconia. And you can see a slightly pneumatized sinus, very slightly, it's pneumatized, okay? So for those of you who have not still started the ACG course, make sure you visit our website for more information at www.confidentis.ca. I don't take any more of your time. We'll do the last X-ray because it's almost 5:54, and then we call it a day. Okay, so let's begin. Periodontal bone loss, so obvious. Yes. No tooth fracture, no extrusion, root caries, very obvious. These radiolucents, these root caries. Calculus, yes, I can see on the mesial surface. Okay. No cervical burnout, no root resorption, no condensing osteitis, and yes, we have alveolar ridge atrophy. And no pulpal arbitration, attrition, no normal anatomic landmark. So answers are A, D, E, and I. 0.25 each. Okay. Can I choose 4 for distal cervical burnout? Not really, no. I need a little bit more radiolucency to this. It's just so thin, that radiolucency I see between CJ and the alveolar bone. Okay. And can I choose extrusion for 2-4-3? Again, no. For choosing extrusion, I should clearly see the occlusal surface. Maybe a bite wing would be a better choice than a preapical, especially with this quality. It can be maybe an overlap. I should be able to compare it with the adjacent teeth. So this one is too risky. So this is considered as an easy question, though. Let me show you actually the next one, and actually like this one. Let's do this one as the last question. Okay, guys, so let's just take a look at the question. So first we have bone loss, no evidence of bone loss. External root resorption, nope. We have physiologic root resorption, that's not considered as external root resorption. No internal root resorption, no PCOD, no evidence of odontogenic cyst or tumors. Arrested root development, no. Make sure you check the definition of arrested root development, important. It can be caused by trauma. It can be caused by, for example, situations like dens vaginatus, pretty important. Developing tooth follicle, yes, we have tons of developing tooth follicle. Okay, so tons of them. Jaw fracture, no. Preapical radiolucency, nope. There is no preapical radiolucency. But I think that the tricky part of this question is the age of this patient. So far our answer is option G. Is this patient 6 to 7 or is this patient 8 to 9? So between the two, I go with J. This patient is 6 to 7. Several reasons. Look at the lower canine. They erupt at age 9, not erupted. Look at the lateral incisors. They erupt at age 8, not erupted. Look at the first molar. The roots are not completely formed. Roots of the first molar usually form at age 8 to 9. Look at the lower lateral incisors. They look like they recently erupted. They erupt at age around 7. Look at the central incisors. They look like they are recently erupted. They erupt at age 7, okay? So putting all these together, 6 to 7 is a more appropriate range. The age of this patient, if you're asking me accurately, is 7. And this patient was actually 7. She was 6 years and 11 months. And the option J is the right answer. So 0.5 and 0.5, okay? So we had some more questions, but I think that's good for today. Hopefully, we're gonna have more of these sessions together. We try to do it at least once a month. So it's going to be more like a practice session. Can be in different topics. Maybe next time it's going to be in emergencies or perio. So definitely there's going to be more sessions. We try to record these sessions and put them on our YouTube channel. So make sure you follow our YouTube channel, and we'll be in touch. Hopefully we'll see you very soon, okay? So I wish you guys all the best. Enjoy the rest of your day, and we'll get back together soon, okay? Take care of yourself. Thank you, thank you.